We request everyone to mute their mic so that Dr. Bhuma can give us the welcome address.
Good morning, one and all. So as the theme suggests, embracing the new normal in healthcare, hospitals across the world are facing never before seen challenges that have accelerated the development of technological innovations. As we navigate the complexities of the virus and the amount of disruption it has brought about, one thing is certain, COVID-19 will be with us for the foreseeable future. So we should now focus our efforts on this new reality and how we can achieve a sense of normalcy. So on behalf of Faculty of Management Sciences and Srihar, it is my pleasure to welcome the great panelists and hear from them on the theme Embracing New Normal in Healthcare, aligned with the latest knowledge. I also welcome the academicians, students, and participants from various sectors, India and abroad. We are all acutely aware of the crisis associated with COVID-19 all over the world. So that thus it is timely that this panel discussion will enable us and all the attendees to know the critical issues in this escalating problem. So I invite Dr. Shubha to start to introducing the panelists one by one, and so that we can proceed from there. Thank you all and welcome.
Thank you, ma'am. And to Sumant being the first speaker of the panel. And Dr. Sumant has an MD in General and diploma in communications. He is presently the domain consultant at TCS. Please, my dear friends, my dear students, he wears another cap apart from his healthcare cap. With media from the time he had his MBBS in brackets. And I have admired his knowledge sports records on his fingertips, for which he is already part of the Limca Book of Records. He has number of awards to his credit, and I have the credit of having worked with him for an HMS EMR implementation. And thanks for accepting our request, and thanks for being part of this session, Dr. Sumant. And over to you now.
Yeah. Good morning to all the panelists and those who are participating in this event. First of all, let me say I'm honored. It's a fanboy moment for me to be with Dr. Narottam Puri, who I've grown up admiring for his great skills as a cricket commentator. In fact, he was one of those I used to look up to for many years. So that's one. And all the other esteemed panelists who are here, Dr. Jabamale, old family friend for 30 years and so on. So I'm very happy to be here to participate in this event. I'm just going to talk very briefly about what opportunities. I know COVID is not an area where we normally look at opportunities. We look more at threats and we look at risk mitigation, as it were. But as far as the healthcare sector is concerned, I think COVID has probably presented us far more opportunities in terms of adopting technologies successfully to delivering healthcare. And we could look at, I'm just going to take a few minutes to talk about some of the key points there. One of the key aspects as far as the opportunities are concerned is the huge increase in teleconsultations. Before COVID, telemedicine has been around only for the last 30 years plus, predominantly stuck at university hospitals, charitable institutions, and a handful of corporate hospitals. And most of it was what we used to call in India as photo op telemedicine. You get some VIP to inaugurate something, take a few photographs with the minister, and after that, the room will be locked up for the next 1 year. So that has changed. Thanks to COVID, today we have a significant reluctance on the part of the patient to come to the clinic or to the hospital. And I'm sure some of you would have read the New York Times article, which spoke about where have all the heart attacks gone. So clearly, there is a huge increase in teleconsultations. And for many conditions, let's be very honest, especially for reviews, may not be that much for new patients, but for reviews, a diabetic is being reviewed for, whether to continue his medication or not. Many of those patients do not necessarily need to turn up in person. Hospitals don't like telemedicine, doctors don't like telemedicine because it cuts the revenue of the institution substantially. When somebody turns up in front of you, you can order a few more tests. Those tests are done at your institution. That adds to revenues. But at the end of the day, if the patient is going to drive this form of consultation, I think the healthcare industry had better get prepared for that. The second major transformation that we've seen is in terms of routine, quote unquote, what we call routine visits to the hospital or to the doctor. Now, all of us know that those have drastically come down over the last 9 to 10 months in India. And we will have, in fact, most of the surgeons tell you very clearly that elective surgeries have crashed and they really haven't picked up in any significant way as yet. So what does that tell us? It probably tells us that there is a fair amount of overdiagnosis that has been going on in the healthcare industry. And we need to take a long, hard look at how, what percentage of the tests that are being ordered, the medication that are being given, the procedures that are being done, the surgeries that are being undertaken, what proportion of them really are necessary and contribute to, not doing them would lead to an increase in morbidity and mortality. This is very, very important because globally, I can tell you the statistics, close to 30% of all tests and procedures are deemed to be unnecessary. In fact, there are lists which are available which actually tell you which are the top 10 most unnecessary procedures and tests that are being done. Now, what COVID has given us is this opportunity to reassess. Now, whether we want to do it or not is a different issue. Corporate hospitals will be aghast at the idea. But from a country, from the perspective of a country and a population like India's, where we are honestly, struggling to provide healthcare for almost 85% of our population with any kind of quality at all, we need to reassess and we need to look at these protocols very, very carefully. I'm going to give you a little example. I'm sure most of you are aware of this, of the stress testing, example of stress testing, and how they used to do a TMT, a treadmill test routinely for patients in the US, and they did a study. And actually, it was then a collaborative study with different countries in the world. And what they actually found was increased stress testing caused a significant increase in coronary angiograms, angioplasties, bypass surgeries. But, and here is the important part, it had very little impact on mortality rates over a period of time. So then, if it is not significantly going to impact either the morbidity, the percentage of MIs that happened over the year, I'm sure this is a very, very landmark study. I'm sure most of you will be aware of it. Why were so many treadmill tests being done? Now in India, every corporate hospital has healthcare packages which say a TMT is done every time for the busy corporate executive. Now abroad, most hospitals do not do treadmill tests for non-high risk asymptomatic patients. Age alone is not a criteria for a treadmill test. But unfortunately, we have this practice. So I think a lot of these practices can be reassessed. We have to step back and think, first of all, the patient comes at the center of the healthcare process. I think at the end of the day, his welfare needs to determine whatever else goes around in the healthcare industry. The other area is in the area of diagnostics. And I'm sure many of you would be aware of the instant diagnostic kits that have come about. Sanjeev will be talking about some of it a little later. But why is it that a lot of the diagnosis cannot be done remotely? Today it can. And we are working, not just in TCS, but the entire healthcare industry globally is working on models that can reduce the lead time to diagnosis. okay, we've done this test, it will take 4 days for the result to come, or the sonologist will come in the evening, the MRI you can do tomorrow. Today, science and technology is so advanced in healthcare that a diagnosis of most conditions should be made in minutes, if not in hours. Unfortunately, even today in India, diagnosis itself takes days and comes with all its attendant stresses, attendant costs, and so on. So the era of instant diagnostics, I'm sure many of you would have seen the report today. COVID, RT-PCR, 8 hours processing time. In some countries, results were coming after 4 days. When? And that was in the month of May, June, and July, hardly 5 months ago. And today, the FDA has approved an instant test which gives you a result in 20 minutes through a home kit nasal swab. What has been the time to get this off the ground? Just 5 months from the day the RT-PCR tests were considered as the norm. So I think we are moving towards an era where we need to look very carefully at what is the kind of healthcare that we are delivering. Who is this healthcare being delivered for? Is it being delivered for the healthcare industry? Of course, patients have to be at the center of it, but at some point, COVID, I think, has given us an opportunity. The last point I will touch on is about automated diagnostic systems. We've been working in that area for about 15 years, and that is me personally, but I'm talking about as an industry globally. Decision support systems are now 25 years old. Adoption rates have been abysmal. Again, the challenges that we face are again going against an industry which to a large extent feels threatened by the existence of such systems. So when we used to go in and talk about these systems, the first response would be, are you telling me that a computer will diagnose better than me? Does the computer have my experience, and so on? I mean, that was a colloquial way of putting it. But today we know that decision support systems diagnose several conditions better than 95% of physicians of comparable skills in the best geographies in the world. Unfortunately, these systems still do not find public acceptance. Look, I always keep asking this question: how accurate is your doctor with his diagnosis? And the answer is nobody knows. None of us in this country know how skilled or how good. It may be by hearsay, it may be by talking to colleagues who may share a good or bad experience, but there is no objective way today to know how good or how accurate a doctor has been with the diagnosis. Yet, when we take an automated system, we say they need to be 100% accurate. No, 98. My God, you mean to say it will be wrong in 2% of the time? No. How accurate is your doctor? We don't know. Is he 80% accurate? 99% accurate? We have no clue of finding out. And we are not interested in finding out. Neither is the private sector want to do it, nor does the government want to do it. So I've been putting this point across that we need to move towards the era of decision support systems in a big way. That is the only way that you can take out the three big problems: access, affordability, and quality. Access, a decision support system can be made available on a mobile phone, so you're solving an access problem. Affordability, you can give it away free for all that one knows, or at a nominal cost. You're making it affordable. And the quality is benchmarked with the best in the business or the best in the industry. Therefore, you have the three major problems. I can't see a doctor because he isn't there in my village. I can't afford to go to the corporate hospital even though I live near one, and I have no clue as to the quality of what I'm getting in these hospitals. All three problems get taken out to a considerable degree by using automated systems. I'll just end with just two quick points. One is on the automated reading of X-rays. I'm sure some of you chest X-rays. Sanjeev will talk about it, but I'll just touch upon it. It is now being mainstreamed in some countries in the world. So only those flagged as abnormal are actually picked up for further manual evaluation by a radiologist. The same is happening with CTs and MRs. It's a matter of maybe 4 or 5 years before we move in. So technology has given us this opportunity. Today, let me ask you a simple question. Technology, an ECG machine in an ambulance, which can transmit the data to the hospital or to a cardiologist, costs 8,000 rupees. 8,000 rupees in India today. How many of our ambulances are equipped with this? None. Or maybe 5%, 2% of the ambulances. 95% of ambulances in India do not have the capability of syncing and transmitting the ECGs to the cardiologist and get an instant opinion. So you don't know until the patient comes to the hospital, and we know we talk about the golden hour in cardiac cases. We talk about so many things in terms of the necessity for speed, but using technology, as I keep saying, we don't need to use today's technology. If we used day before yesterday's technology, we could make a huge impact on the quality of care that we are able to deliver. COVID has given us a massive opportunity, and I think that it is our duty to take this opportunity, grab this opportunity with both hands. But most importantly, the solution cannot be more medical colleges, more doctors, more hospitals. That is not going to solve your problem, simply because the issues are not just of numbers, they are of distribution, they are of quality. And as long as we don't focus on that, we can't make the impact that we want to. So please let us look at this as an opportunity and not as a threat. And my request to all the seniors on this panel is to please take it upon, because you are all thought leaders, you are all industry leaders. So if you take it upon yourself to tell and accept disruptive innovation, and I think healthcare, if any industry needs disruption, it is healthcare. So thank you for your time. Yeah. Hello.